Hello everyone. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator, wherein in this session I'll be discussing a very important topic, that is the pneumothorax. So pneumothorax, it is one of the very important medical emergency. And why it is a medical emergency? Because in these patients with pneumothorax, the individual will have the development of the collapsed lung. And you should understand what exactly is the pneumothorax. Pneumothorax is a clinical scenario where you have accumulation of air in the pleural space. Right? Accumulation of air in the pleural space. And it is the excessive accumulation of air in the pleural space. That is what is called as the pneumothorax. And because of this excessive accumulation of air in the pleural space, that will make the individual to develop what is called a collapsed lung. And the development of collapsed lung, it is the hallmark of pneumothorax, and that is the reason why this pneumothorax is considered as the medical emergency. Now, how do we classify the pneumothorax? Pneumothorax, it is being classified as spontaneous pneumothorax, right? Next, traumatic pneumothorax, and iatrogenic pneumothorax. So this is the classification of the pneumothorax: spontaneous, traumatic, and as well as the iatrogenic pneumothorax. Now, so where exactly the air enters in case of pneumothorax? Pneumothorax, the air enters between the visceral pleura, right? The air, it enters between the visceral pleura and the parietal pleura. Right? The air enters between the visceral and as well as the parietal pleura. So that is what exactly happens in patients with the pneumothorax. Now, let me discuss like this spontaneous pneumothorax, traumatic pneumothorax, and as well as the iatrogenic pneumothorax. So, if you take this primary spontaneous pneumothorax, again we have two subtypes. One is primary spontaneous pneumothorax and the other one is secondary spontaneous pneumothorax. Now, what is this primary spontaneous pneumothorax? Primary spontaneous pneumothorax occurs in the absence of an underlying lung disease, right? So it occurs in the absence of underlying lung disease. That is what is your primary spontaneous pneumothorax. Okay, next, you take in case of secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax, it is a complication of pre-existing lung disease, right? It is a complication of pre-existing lung disease. Okay, so that is what is your secondary spontaneous pneumothorax. There is no underlying lung disease, but the individual has developed pneumothorax, that is primary spontaneous. And there is a pre-existing lung disease and the individual has developed pneumothorax, that is the secondary spontaneous pneumothorax. Then another important terminology what we have is the traumatic pneumothorax. Now, what is this traumatic pneumothorax? It results from penetrating or blunt trauma to the chest. Right? Penetrating or blunt trauma to the chest. That is what is your traumatic pneumothorax. Then we have another important terminology called as the iatrogenic pneumothorax. Iatrogenic pneumothorax, it may follow certain procedures, right? And what are those procedures which may lead to the development of iatrogenic pneumothorax? Number one, thoracocentesis. Right? So, where will you come across this thoracocentesis? Thoracocentesis, is nothing but pluricentesis, where there is excessive accumulation of the fluid in the pleural space. In that scenario, we will try to drain out this particular fluid, and that particular procedure is called as pluricentesis or thoracocentesis. And pleural biopsy. Right, so during the procedure of pleural biopsy, the individual can develop iatrogenic pneumothorax. Then, during the placement of central venous catheter, that is subclavian or internal jugular venous catheter placement. Right, so during this particular catheter placement, there can be development of the iatrogenic pneumothorax. And another important procedure which can make the individual to develop this iatrogenic pneumothorax is during bronchoscopy. So when you are doing bronchoscopy, right, when you are doing bronchoscopy with transbronchial biopsy, right, you are doing bronchoscopy and you are trying to take a biopsy, there is a chance of complication of development of pneumothorax, and that we call it as iatrogenic pneumothorax. Or during positive pressure ventilation. Right, during positive pressure ventilation, the individual can develop a pneumothorax, and that we call it as iatrogenic pneumothorax. Now, so this is the classification of pneumothorax. One is spontaneous, which we classify that again into primary and as well as secondary spontaneous pneumothorax, and then traumatic pneumothorax, and then iatrogenic pneumothorax. Next, we have another important type of pneumothorax which we call it as the tension pneumothorax. Now, what do you understand by this terminology, that is tension pneumothorax? Tension pneumothorax, it is the more severe form of pneumothorax. What happens in case of the tension pneumothorax is that the air, it enters into the pleural space. Right, the air, it enters into the pleural space, similar to that of the other forms of pneumothorax what we have discussed. But the air which has entered into the pleural space, right, the air which has entered into the pleural space, what happens there is excessive increase in the pleural pressure, right? So the pressure in the pleura is very high, and this excessive increase in pressure in the pleura, it almost exceeds the alveolar and as well as venous pressure. Right, it exceeds alveolar pressure and as well as the venous pressure. So venous pressure in the sense that is the pressure in the superior vena cava and as well as the inferior vena cava. So the pressure in the pleural space is much more than compared to that of the alveolar and as well as the venous pressure throughout the respiratory cycle. Now, this excessive increase in the pressure within the alveoli and as well as the pleural space, what it will do is, it will cause the reduction of venous return. Right, it will cause the reduction of venous return. And once there is reduction in the venous return, what will happen to the cardiac output? It is decreased. So once the cardiac output is decreased, the blood pressure is reduced. So there will be development of hypoperfusion to the organs, and that will make the individual to develop an end organ damage. That is what will happen in patients with the tension pneumothorax. Now the question is, why the pressure in the pleural space is very high? Why that particular pathology develops in tension pneumothorax? Let me tell you. So you have to understand a mechanism called as the check valve mechanism. Right, you have to understand a mechanism called as the check valve mechanism. Now, what do you mean by this check valve mechanism? Right, what do you mean by this check valve mechanism? So, in case of check valve mechanism, what will happen is the air enters into the pleural space, right, from the lung, the air enters into the pleural space, okay, on inspiration. But the same air, it does not enter from the pleural space into the alveoli during expiration. This will not occur. Why? Because you have a check valve. What does this check valve do? This check valve will allow air to enter into the pleural space on inspiration, but it will prevent the egress of air on expiration. And with every inspiration, there will be accumulation of air within the pleural space. Right? With every inspiration, there will be accumulation of air within the pleural space. And thereby, the pleural pressure is so high than compared to that of your venous pressure. And that is the reason why the venous return will be reduced. Now, what are the etiologies for the development of the pneumothorax? Right? Let me tell you the etiologies of the pneumothorax. Etiologies of pneumothorax, it includes number 1, penetrating trauma to the chest, and next important etiology which can cause the tension pneumothorax include lung infection or pulmonary infection, then followed by that cardiopulmonary resuscitation, and then followed by that cardiopulmonary resuscitation, then positive pressure mechanical ventilation. Right? Positive pressure mechanical ventilation. So, these are all the etiologies which can make the individual to develop what is called the tension pneumothorax. And let me tell you, tension pneumothorax, it is a very, very critical condition. And this tension pneumothorax, it requires immediate treatment. Right? It requires immediate treatment. What you have to do? You have to take a wide bore needle and puncture the pleura in the upper intercostal space. Right? So, with the help of wide bore needle, you need to puncture the pleura in the upper intercostal space. That will release the air. And if the individual breathlessness or if the pneumothorax is not still subsided, the next step will be chest tube drainage. Right? The next step will be the chest tube drainage. So, this is what is your tension pneumothorax, which is an important medical emergency. Next. Now, let me just summarize all forms of pneumothorax what we have discussed. So, traumatic pneumothorax, spontaneous pneumothorax. Traumatic pneumothorax, it could be in the form of blunt trauma, penetrating trauma, and we also have iatrogenic, which comes under your traumatic pneumothorax, or it can be taken as a separate entity as well. In spontaneous pneumothorax, that is primary spontaneous and secondary spontaneous. Primary spontaneous, you don't have any underlying lung disease. This primary spontaneous pneumothorax, let me tell you, it is most commonly seen in tall, thin, male smokers. Right? This primary spontaneous pneumothorax, it is seen in tall, thin, male smokers. Whereas secondary spontaneous pneumothorax is the one which occurs in the presence of an underlying lung disease. Right? Which occurs in the presence of an underlying lung disease, or it occurs as a complication of an underlying lung disease. So that is about the classification of pneumothorax. Now let me discuss what are the various etiologies which can cause pneumothorax. And accordingly you see a question. Pneumothorax is seen in all except Marfan syndrome, assisted ventilation, eosinophilic granuloma, bronchopulmonary asthma. See, you can have a question on the etiology in the following manner. Now, let me discuss all the etiologies. Right? You have many etiologies which will cause pneumothorax, and at the end, I will also give you a mnemonic to remember all these particular etiologies. Okay. So these important etiologies, they include number 1, the obstructive lung diseases. And these obstructive lung diseases, it includes COPD and as well as the asthma. So you have to understand that if COPD or asthma, if these patients, they progress to the development of pneumothorax, what type of pneumothorax? We call it as secondary spontaneous pneumothorax, because there is an underlying lung disease there. And interstitial lung disease, right? Even this also comes under your same secondary spontaneous pneumothorax. And these etiologies include number 1, idiopathic pulmonary fibrosis, right? And next important etiology or next important interstitial lung disease which will cause secondary spontaneous pneumothorax will be your eosinophilic granuloma. Right, eosinophilic granuloma. Now, what is this particular eosinophilic granuloma? Eosinophilic granuloma, it is a form of Langerhans cells histiocytosis. And the other condition which will cause secondary spontaneous pneumothorax is sarcoidosis. Then followed by that, malignancies. What are the malignancies which will cause secondary spontaneous pneumothorax? That is primary lung carcinoma, that is nothing but your bronchogenic carcinoma. And not only this primary carcinoma of the lung, even pulmonary metastasis, even this also can progress to the development of secondary spontaneous pneumothorax. And lastly, complication of the chemotherapy. Right, complication of the chemotherapy. So these are the etiologies which can cause the secondary spontaneous pneumothorax. And apart from that, we also have some infections which can cause the secondary spontaneous pneumothorax, and that infections include Pneumocystis carinii pneumonia, which we call it as Pneumocystis jirovecii pneumonia in the recent days, tuberculosis, then acute bacterial infection. Right, acute bacterial infection. So these are the infections which can cause the secondary spontaneous pneumothorax. And connective tissue disorders, if you see, that includes rheumatoid arthritis. Right, rheumatoid arthritis, it is mainly the disease of the joints, small joints. But in rheumatoid arthritis, you also have extra-articular manifestation. And the pulmonary manifestation, it can be in the form of interstitial lung disease. It can be in the form of pulmonary nodules. It can be in the form of even pneumothorax as well. Then, another important connective tissue disorder is the ankylosing spondylitis. See, even in case of the ankylosing spondylitis, mainly the sacroiliac joint is affected and as well as the spine is affected. So there will be degeneration of the sacroiliac joint and there will be fusion of the vertebra within the spine. That you will have in patients with ankylosing spondylitis. Even in ankylosing spondylitis, you have extra-articular manifestation and the pulmonary manifestation will be in the form of your pneumothorax. And another important connective tissue disorder is Marfan syndrome. So in these patients with the Marfan syndrome, if you observe the stature, right, so they are like very tall stature. And another important connective tissue disorder is EDS. So what does this EDS stands for? Ehlers-Danlos syndrome. Now, apart from these connective tissue disorders, we have some miscellaneous causes for the development of your pneumothorax. Now, what are those miscellaneous causes which will cause the pneumothorax? That includes catamenial pneumothorax. Now, what do you understand by this word catamenial pneumothorax? I will discuss that in detail. And next to this particular catamenial pneumothorax, we have pulmonary infarction, which can cause pneumothorax, then pulmonary hemorrhage, then a small vessel vasculitis, that is your Wegener's granulomatosis. Right, Wegener's granulomatosis. Then lastly, von Recklinghausen's disease. Von Recklinghausen's disease. So these are the causes for the development of your pneumothorax. So we have discussed like multiple etiologies. So how to remember all these multiple etiologies? I'll give you a mnemonic for this. And that particular mnemonic is A, B, C, D, E, F, G, H, I. Right? A is your abscess. That is infection within the lung abscess. And this particular lung abscess or infection within the lung, it could be secondary to your tuberculosis. It could be secondary to your acute bacterial infection. It could be even secondary to your pneumocystis jirovecii pneumonia as well. And bacterial pneumonias and necrotizing pneumonia, B. And C will be your COPD, cavity, cystic fibrosis, congenital cyst formation, and then malignancy, that is the cancer. So that is what the letter C stands for. These are all the etiologies that can cause the pneumothorax. And D is your draining, that is thoracocentesis. That is nothing but your pluricentesis. That will be responsible for the development of iatrogenic pneumothorax. E stands for esophageal rupture and endometriosis. And regarding this pulmonary endometriosis causing pneumothorax, that is nothing but your catamenial pneumothorax. I'll discuss that in detail in few minutes. F will be fractured ribs. So that would be secondary to your trauma, right? G stands for gunshot injuries or the knife injuries. H, right, you will see this pneumothorax in patients suffering with HIV, and in patients with suffering with HIV, the cause for the pneumothorax will be pneumocystis jirovecii pneumonia, then followed by that the iatrogenic causes. See, the iatrogenic causes for the development of pneumothorax will be thoracocentesis or pluricentesis, pleural biopsy, central venous catheter insertion, bronchoscopy with transbronchial biopsy, and then positive end expiratory pressure. So these are all the various causes for the development of your pneumothorax. Now let me discuss in detail about this endometriosis, which we call it as the catamenial lung disorders. Okay, so what do you understand by this word catamenial? The word catamenial is that it is the disorders, or it is a group of disorders that you will see in females during menstruation. Right, you will observe that during menstruation. So that is what you mean by the word catamenial lung diseases. And what will be the presentation of these patients with the catamenial lung diseases? These patients, they present with dyspnea. Right, these patients, they present with dyspnea. That is catamenial pneumothorax patient, they present with dyspnea. Now what is the reason for the development of these catamenial lung diseases? That is due to development of pulmonary endometriosis. So what do you understand by this word pulmonary endometriosis? See, endometriosis, what do you mean by that? It is the presence of the endometrial tissue outside the uterus is what is called as endometriosis. Pulmonary endometriosis, what do you mean by that? The presence of the endometrial tissue outside the uterus, that is in the lung. That is what is called as the pulmonary endometriosis. Right, so this is nothing but your catamenial lung disorders. Now going back to our question, like what we have discussed initially regarding the etiology. Pneumothorax is seen in all except Marfan syndrome, connective tissue disorder, which can cause the pneumothorax. Assisted ventilation, particularly positive end expiratory pressure, can make the individual to develop pneumothorax. Eosinophilic granuloma, it is a form of an interstitial lung disease, right, where you have the Langhans cells histiocytosis, where the individual will develop pneumothorax. And where you will not have pneumothorax, that is in case of bronchopulmonary aspergillosis. So in bronchopulmonary aspergillosis, the pneumothorax is absent. Now, after having discussed about the etiologies, let me discuss the clinical features. Okay, before going ahead with that, just see one more question. While inserting a central venous catheter, a patient develops respiratory distress. What is the most common cause? The options are hemothorax, pneumothorax, pleural effusion, hypovolemia. The answer is pneumothorax. And what form of pneumothorax is this here? It is iatrogenic pneumothorax. Right? It is your iatrogenic pneumothorax. Now, if you see the next question, all of the following are characteristic feature of primary spontaneous pneumothorax except the options are male gender, old age, tall stature, history of smoking. Now, we have discussed that primary spontaneous pneumothorax is the disorder which will occur in the absence of an underlying lung disease. So, this primary spontaneous pneumothorax, it is seen in tall, thin, male smokers. So, this is the clinical scenario where you have the presence of your primary spontaneous pneumothorax. So, in male gender you will have pneumothorax, tall stature you will have pneumothorax, like for example in case of Marfan's, and history of smoking also there can be development of your pneumothorax, right? But old age is the answer here. So, old age is not like definitely a predisposing factor for the development of your primary spontaneous pneumothorax. Now, having discussed about the etiology in detail, let me discuss the clinical features in patients with the pneumothorax. See, what exactly is the problem here? There is entry of air into the pleural space, and because of which the lung is collapsed. Once the lung is collapsed, the exchange of gases does not occur, and thereby the individual will develop sudden onset dyspnea. Right? The individual will develop sudden onset dyspnea. See, there are multiple etiologies which will cause sudden onset dyspnea. Let me give you the differential diagnosis for your sudden onset dyspnea. Sudden onset dyspnea, if you take in case of the pulmonary pathologies, where all you will come across this? You will come across this in patients with pulmonary embolism, right? And particularly massive pulmonary embolism, the individual can have a sudden onset dyspnea. You can have sudden onset dyspnea in acute exacerbation of COPD and acute exacerbation of the bronchial asthma. Right? Acute exacerbation of COPD and as well as acute exacerbation of bronchial asthma, where you will have the development of sudden onset dyspnea. And another important etiology is pulmonary edema. Right? Another important etiology is pulmonary edema. And that too, the development of pulmonary edema secondary to your acute left ventricular failure, there you can have sudden onset dyspnea, and that we call it as cardiogenic pulmonary edema. And another important etiology where you can have sudden onset dyspnea will be ARDS, that is acute respiratory distress syndrome. Then you can have sudden onset dyspnea in case of the aspiration, right? And you can have the sudden onset dyspnea in case of the hypersensitivity reactions, that is in anaphylaxis. Right, that is your anaphylaxis. So these are all the causes for the development of the sudden onset dyspnea. Right. Now, so in patients with pneumothorax, the clinical presentation will be in the form of sudden onset dyspnea. Then what are the other features? These individuals, they can have pleuritic chest pain. Right, pleuritic chest pain. Okay. Now, on examination, what will you observe in patients with pneumothorax? On examination, patient prefers to lie on the affected side. Right, the patient prefers to lie on the affected side. Now the question is why. Like for example, we will consider if the individual has developed left-sided pneumothorax, the patient will prefer to lie on the left side. Why? Because when the individual lies on the left side, the right lung will have an adequate space for expansion within the thoracic cavity. And that is the reason why the patient will prefer to lie on the affected side. And these patients, if you take the respiratory rate is very high, and that we call it as tachypnea. Right, that we call it as tachypnea. And there is also increase in the heart rate, right, that we call it as tachycardia. And if you observe the chest movements on the affected side, there will be diminished chest movements, right, there will be diminished chest movements on the affected side. Why? Because the lung is collapsed there. So that is the reason why if you observe the chest movements are reduced. And even if you observe the trachea is deviated to the opposite side, right? I'll show you an X-ray where you have pneumothorax and the trachea deviated to the opposite side. Now, the question is why the trachea is deviated to opposite side. You see here, this is an important X-ray of the pneumothorax. So, it is the pneumothorax of the right lung, right? It is a pneumothorax of the right lung. So, the pressure within the pleural space, right? The pressure in the pleural space is very much increased, and that will push the mediastinum to the opposite side, right? That will push the mediastinum to the opposite side. And you can observe here the trachea being shifted to the opposite side. Okay, next. That is what you will observe on inspection. Then on palpation, what is that you will be able to make out? On palpation, the vocal fremitus is decreased. Right, on palpation, the vocal fremitus is decreased. So, how will you elicit this vocal fremitus? You need to keep the ulnar aspect of the hand over the surface of the chest, and the individual is asked to speak. And the vibrations which are generated within the lung parenchyma is transmitted to the chest wall, and that is being felt by the ulnar aspect of the hand what you have placed over the surface of the chest. But in these patients, what is happening? The lung is collapsed. So, you don't have the adequate vibrations which have been generated within the lung parenchyma, and you don't have the transmission of those vibrations onto the surface of the chest, and thereby your vocal fremitus will be reduced or absent. Then, what will happen to the percussion note? Percussion note, you will have the hyperresonant note, right? Percussion note, you have the hyperresonant note. And why is this particular hyperresonant note? That is mainly because of the presence of air in excess quantity in the lung, right? That is because of the presence of air in excess quantity within the lung. That is what is your percussion note. Next, now you observe the liver dullness. Like for example, right? For example, if there is right-sided pneumothorax, right? If the individual has developed right-sided pneumothorax, in right-sided pneumothorax, what will happen is there will be obliteration of the liver dullness, right? There will be obliteration of the liver dullness. Why? Because the air within the pleural space will overlap the liver border. The air in the pleural space, once it overlaps the liver border or the liver edge, then there will be obliteration of your liver dullness. So, where will you feel for the liver dullness in a normal individual? In a normal individual, you will have this liver dullness in the fifth right intercostal space. Right? So, in the fifth right intercostal space, you will feel for this particular, right? You will feel for this particular the liver dullness. So, in patients with right-sided pneumothorax, there is a very high chance that the liver dullness which is being felt in the fifth right intercostal space, it gets obliterated, right? Then, we have a very important sign that is called as the Hamann sign. What do you understand by this Hamann sign? You will have this Hamann sign mainly in patients with mediastinal emphysema. What is emphysema? It is nothing but the accumulation of a pocket of air within the mediastinum. And this pocket of air, it can get ruptured, where the individual will develop the left-sided pneumothorax. Right, where the individual will develop left-sided pneumothorax. Okay. Now, what happens here in patients with mediastinal emphysema? So, what is this? It is a pocket of air, right? It is a pocket of air which is accumulated within the mediastinum. So, with every heartbeat, right, with every heartbeat, the heart will be touching this particular pocket of air, and thereby there will be production of a crunching sound, right? Thereby there will be a production of a crunching sound with each heartbeat. That we call it as Hamann sign, right? So Hamann sign is a crunching sound which is synchronous with the heartbeat, which is heard over the precordium in spontaneous mediastinal emphysema. And this mediastinal emphysema can progress to the development of your left-sided pneumothorax. Now, regarding the percussion note, already we have discussed, it is the hyperresonant note. And at the same time, you should know what are the differential diagnoses for the hyperresonant note. It is not only just pneumothorax where you have the hyperresonant note. You will have this hyperresonant note even in patients with COPD, right? And that too, which subtype of COPD? That is in patients with emphysema, right? In patients with emphysema, you have the presence of this particular, the hyperresonant note. Then, followed by that, what will happen to the breath sounds? See, breath sounds on the affected side, I have already said you, they are absent. Why the breath sounds will be absent? Right? Why the breath sounds will be absent? Because the lung is collapsed there. That is the reason why there is no air entry. So your breath sounds are completely lost. But in patients with tension pneumothorax, you will hear a form of bronchial breath sounds, and that is nothing but your amphoric breath sounds. Right, that is nothing but amphoric breath sounds. So you will hear the amphoric breath sounds in patients with the tension pneumothorax. And these amphoric breath sounds are those of metallic quality. Right, amphoric breath sounds are those of metallic quality, that we call it as the amphoric breath sounds, right? It is a form of bronchial breath sounds. See, actually bronchial breath sounds, we have the following types. We have tubular type of bronchial breath sounds, which we see that in consolidation. Then cavernous type of bronchial breath sounds, which you will see that over a pulmonary cavity. Amphoric type of breath sounds, you will have that in patients with the tension pneumothorax, right? So this is about the clinical presentation and as well as the examination findings in patients with the pneumothorax. Now, I'll just show you one important clinical scenario, that is, a 30-year-old female comes with acute onset breathlessness. Neck veins are distended and there is absent breath sounds and mediastinum is shifted. Which of the following should be done immediately? HRCT should be done immediately. Arterial blood gas analysis should be done immediately. Chest X-ray should be done immediately. Large bore needle puncture of the pleura should be done immediately. Right. Now this is a medical emergency here, right? The acute onset breathlessness, neck veins are distended, absent breath sounds, mediastinum is shifted. So how is that you are able to make out that the mediastinum is shifted? That is, the trachea is shifted to the opposite side. See, it is a classical picture, right? It is a very classical picture of your pneumothorax. So please don't waste time in doing the investigations. What is that you have to do immediately? Large bore needle puncture of the, and where is that large bore needle you will puncture? You will puncture this particular large bore needle into the second intercostal space, right, into the second intercostal space. So that is about your large bore needle puncture of the pleura. Now, followed by this, now see, why is that you should not waste time in doing the chest x-ray and all? Why is that you should not waste time in doing the other investigations? Because neck veins are distended means what does that represent? It represents that the venous return to the right side of the heart is reduced. That is the reason why your neck veins are being distended. And when the venous return is reduced, subsequently the cardiac output will be reduced, and subsequently the individual will develop hypotension, and that can cause the infarction of your brain. That can cause the infarction of your myocardium. That can cause the infarction of many organs. So in order to prevent that, immediately you have to do large bore needle puncture of the pleura. Then coming to the laboratory diagnosis in patients with the pneumothorax. So immediately the investigations that can be done is ABG, chest x-ray. What does the ABG shows? ABG as such, it is unnecessary, right? No, it is not an emergency investigation which is required in pneumothorax. But if you do an ABG in patients with pneumothorax, that will show you the presence of the hypoxemia, right? That will reveal the hypoxemia, and there will be acute respiratory alkalosis. Now, why is that the individual will develop acute respiratory alkalosis? That is because these individuals with pneumothorax, they have tachypnea. There is increase in the respiratory rate. There will be carbon dioxide washout, right? So because of increase in the respiratory rate, there will be carbon dioxide washout. And because of this carbon dioxide washout, the individual will develop respiratory alkalosis, right? And that is what is seen in most of the patients. And what does the chest x-ray shows? Chest x-ray is a very, very important investigation. So I'll show you the chest x-ray. See, this is the chest x-ray in patients with the pneumothorax. So what is that you are able to make out? In these individuals, you have right-sided pneumothorax, right? You have the presence of right-sided pneumothorax, and there is increased radiolucency, right? There is increased radiolucency on the affected side, and you can observe that lung is collapsed. Right, you can observe that the lung is collapsed. And if you observe the mediastinum, even the mediastinum is shifted to the opposite side. Right, mediastinum shifted to the opposite side. So these are the chest x-ray findings you will have in patients with the pneumothorax. Then followed by that, another important sign is your deep sulcus sign. What is this deep sulcus sign? See, in patients with pneumothorax, when you take a chest x-ray in supine position, right? So in supine patients, pneumothorax on chest x-ray may appear as an abnormally radiolucent costophrenic sulcus. You can see that here. Radiolucent costophrenic sulcus, and this radiolucent costophrenic sulcus is the one which we call it as the deep sulcus sign, right? Which we call it as deep sulcus sign. Next, another important investigation which will be of help is the ECG. Now, what will be the ECG changes? This can be asked. Actually, it's not the investigation which will give you diagnosis, but you may have some questions like, what will be the ECG changes in case of left-sided pneumothorax? Then you should be able to answer that. See, the common ECG findings in patients with the left-sided pneumothorax is that you will observe the presence of right axis deviation. Why is that you will have right axis deviation? Because the mediastinum is shifted to the opposite side. If the individual is having left-sided pneumothorax, the heart which is present in the mediastinum, it is shifted to the opposite side, and because of which the individual can have right axis deviation. There will be reduced R wave amplitude in the precordial leads. Right, reduced R wave amplitude in the precordial leads. So you can observe that here, right? By almost V4, you should have an R wave of more than 3 mm. You should have that R wave more than 3 mm by almost like V3 itself, and gradually it should progress up to V4, V5, V6. But here, what is happening? The collapsed lung is overlapping the heart, and thereby the electrical activity from the heart is not passing to the surface of the chest, and that is the reason why your V3, V4 is unable to pick up the electrical activity, and due to which there will be reduced amplitude of the R wave in the precordial leads. And you also have P wave inversions. So what happens is, sometimes the ECG of the pneumothorax, it may be misinterpreted as an acute MI. Right, it can be misinterpreted as an acute MI. Why? Because there is 1 point poor R wave progression, and you see here you have the presence of a minimal ST segment elevation in lead 2. So this you need to take care, right? You should be able to differentiate whether it is an acute MI or whether it is a pneumothorax by other concomitant findings. If it is an MI in ECG, what is that you will have? You will have reciprocal changes. You will have dynamic changes in the ECG as the time progresses. The same you will not observe in the ECG of the pneumothorax. So these are the investigations related to your pneumothorax. Now, coming to the complications of pneumothorax. See, tension pneumothorax is one of the very important complications. This tension pneumothorax it is a life-threatening condition. Right, it is a life-threatening condition. And another important complication is there can be development of pneumomediastinum and there can be development of subcutaneous emphysema. And this pneumomediastinum, the word pneumo is air, mediastinum is the structure or the part which is present between the two lungs. So there can be accumulation of air within the mediastinum and there can be development of subcutaneous emphysema. Right, there can be development of subcutaneous emphysema. So this pneumomediastinum and subcutaneous emphysema, both of them, they may occur as a complication of spontaneous pneumothorax. And for suppose, if this pneumomediastinum is detected, rupture of esophagus or bronchus should be considered as one of the differential diagnoses, right? So the differential diagnosis for pneumomediastinum is rupture of esophagus, rupture of bronchus should be the differential diagnosis. So these are the complications that you will encounter in patients with pneumothorax. Finally, coming to the management of the patients with the pneumothorax. management or the treatment in pneumothorax completely depends upon the severity of pneumothorax. For suppose, if the individual has developed small primary pneumothorax, if it is a small primary pneumothorax, let me tell you, natural resolution will occur. Right? Natural resolution will occur in few days. They resolve spontaneously. Right? They resolve spontaneously. And this particular air, right, this particular air is absorbed from the pleural space. Right? Air, it is absorbed from the pleural space. That is what you will see in patients with small primary pneumothorax. And in these individuals with small primary pneumothorax, just supplementing the oxygen, that may increase the rate of absorption. So oxygen supplementation will increase the rate of absorption of this small primary pneumothorax. Whereas, if the individual has large primary pneumothorax, and along with large primary pneumothorax there is also dyspnea, then in such case the treatment what you have to do is aspiration with a wide bore needle. Right? In such case you need to do an aspiration with a wide bore needle. And the needle what we use is a 16 gauge needle. Right? The needle what we use is a 16 gauge needle or a 16 gauge angiocatheter or large drainage catheter that has to be placed. Okay? And whenever you do aspiration, there should be the release of air from the pleural space and the pneumothorax should get subsided. Right? Pneumothorax should get subsided. For suppose, if the aspiration with wide bore needle, if it fails, then what is that you need to do? That is the point when you need to insert the chest tube. Right? Which we call it as ICD, that is intercostal drain. Now, what will be the indications? Right? Let me just give you a complete indications for tube thoracostomy. That is your ICD placement. For suppose, if the individual has failed aspiration, right? You have put a wide bore needle and try to aspirate the air, but still the individual is breathless, then you have to put the ICD. Next important thing is presence of large pneumothorax. Right? Presence of large pneumothorax. Development of tension pneumothorax. In these scenarios, you need to do a tube thoracostomy. So, a chest tube is placed underwater seal drainage. Right? So, one side of the chest tube is placed in the pleura and that too at the upper part of the pleura, because air, it has a low density. It actually goes and progresses and it will get accumulated in the upper part. So, that is the reason why the chest tube, you have to progress it to the upper part of your pleura. So, chest tube is placed underwater seal and suction is applied until the lung expands. Right? Until the lung expands. So, that is about the tube thoracostomy. Now, how will you prevent the development of this tension pneumothorax? Like for suppose, if there is risk of development of tension pneumothorax, what you need to do is, you have to place a small bore chest tube right, you need to place a small bore chest tube, and this small bore chest tube, it should be of 7 French or 14 French, and this small bore chest tube, it is attached to, right, it is attached to Heimlich valve. So this small bore chest tube which is attached to this Heimlich valve, this will provide protection against the development of the tension pneumothorax, right? This is a methodology by which you can prevent the development of your tension pneumothorax. And then, for suppose, if the individual is having recurrent pneumothorax, then what is that you have to do? You have to do a thoracoscopy plus pleurodesis. Right, thoracoscopy and then pleurodesis. Now, what will happen, or what is this pleurodesis? Let me explain you. See, pleurodesis is that you need to obliterate the pleural space, and this obliteration of the pleural space is done with the help of chemicals. And what are those chemicals being used? That is either bleomycin or tetracycline. And which particular tetracycline we use? Right, for example, minocycline. And the other chemicals which are being used is povidone iodine, then slurry of talc. They can be introduced into the pleural space through the chest drain, and that will cause the obliteration of the pleural space, which we call it as the pleurodesis. And for suppose, if the individual has more problematic recurrent pneumothorax, then in such case, you need to open the chest, that is thoracotomy, and you have to do pleurectomy, right? You have to strip the pleura out, right? Pleurectomy. Then, what are the scenarios where you have to do this pleurectomy apart from this more problematic recurrent pneumothorax? Or, okay, let me tell you, where can you have this recurrent pneumothorax? You can have this recurrent pneumothorax if there is presence of the emphysematous bulla, and this emphysematous bulla have to be resected out by doing thoracotomy. Otherwise, you will be having continuous recurrent pneumothorax which is being developed. So finally, if you take, now let me tell you the indications for thoracoscopy or open thoracotomy. First and foremost, very important, recurrences of spontaneous pneumothorax. And second, any occurrence of bilateral pneumothorax, right? And if it is a bilateral pneumothorax, definitely it is a very important emergency because both the lungs are collapsed here. And next, third important indication is failure of tube thoracostomy for the first episode. So, in failure of tube thoracostomy, right? So in failure of tube thoracostomy, there is failure of lung to re-expand, or there is like persistent leak. So in this scenario, you need to do thoracoscopy or the open thoracotomy. And surgery, it permits the resection of blebs which are responsible for the pneumothorax. Okay, so resection of blebs, right, mainly in case of emphysematous bulla, that can cause the recurrent pneumothorax. That is also an indication for thoracoscopy or the open thoracotomy. Now, in the treatment part, not only just treating the complication which has developed, you also need to advise certain precautions to the patient. All patients who smoke should be advised to discontinue smoking, right? The individual should stop smoking, discontinue smoking, and warned that the risk of recurrence is 50% if the cigarette smoking is continued. So, if the smoking is continued, there is almost 50% increase in the recurrence of development of the pneumothorax. And another important precaution is these patients, exposure to the high altitude should be avoided. Okay, so high altitude exposure, that has to be avoided. Next, flying in unpressurized aircrafts, right, that should be avoided. And third, scuba diving should be avoided, right? The scuba diving should be avoided. So these are the precautions that has to be set to the patient. Now, you have a very important clinical entity called as pneumocystis jirovecii pneumonia. We have discussed that pneumocystis jirovecii pneumonia is one of the etiology which can cause pneumothorax. Now, there is one important precaution that you need to take whenever you are treating pneumothorax in patients with the pneumocystis pneumonia. Why? Because pneumocystis pneumonia is the one which has the highest recurrence of the development of pneumothorax. Right? The chance of recurrence of pneumothorax is very high with your PCP causing pneumothorax. So, in these patients, like what you need to do is, you need to use a small chest tube, right? A small chest tube that is attached to a Heimlich valve. Right, that is attached to a Heimlich valve that has been proposed to allow the patient to leave the hospital. Right, a small chest tube attached to the Heimlich valve has to be placed to the individual. Okay, and some clinicians, they favor its insertion early in the course of the disease itself. So by this you can prevent the recurrence, right? And this is your ICD, right, where you put the chest tube, and this will be your underwater seal. And overall, how is the prognosis in patients with the pneumothorax? An average of 30% of patients with spontaneous pneumothorax, they experience the recurrence. Right, 30% of patients with spontaneous pneumothorax, right, either it is primary spontaneous or secondary spontaneous. So 30% of patients with spontaneous pneumothorax, they experience the recurrence of the disorder. Right, they experience the recurrence of the disorder. Okay, and recurrence after the surgical therapy is less frequent. So how will you prevent the recurrence? Surgical treatment. Okay, so recurrence after the surgical treatment is less frequent. Okay, this is about the prognosis in patients with the pneumothorax. And finally, if you summarize the pneumothorax, what are the essentials of the diagnosis? First and foremost, the individual will have acute onset dyspnea and as well as the chest pain, right? And if it is like mild pneumothorax, you will have minimal findings, and unilateral chest expansion will be reduced, there will be decreased tactile fremitus or vocal fremitus, there will be hyperresonant note, diminished breath sounds, mediastinum is shifted to the opposite side, and hypotension is seen particularly in patients with the tension pneumothorax. And presence of the pleural air is very much important in the diagnosis of the pneumothorax by chest radiograph. Right, I'll just show you a question here. Which of the following statements about pneumothorax is true? Breath sounds are increased, percussion note is decreased, always needs chest tube insertion, often needs chest tube insertion. What do you think is the answer? The answer is often needs chest tube insertion. It is not always needs chest tube insertion. Please remember this, because it's a small, for example, if the individual has a small pneumothorax that undergo self-resolution, just oxygen supplementation will help in absorption of air from the pleural space. They don't require chest tube insertion always, right? They often needs the chest tube insertion, right? So these are some of the very important points related to your pneumothorax. Thank you very much.